for you to hear me if I stand here. So, good evening, everyone.
Good evening.
Good evening, everyone.
Good evening.
Again, my name is Sharita Jackson Dorsey, and I am the Director of Rural Health for Westside Family Healthcare. I currently work out of the Dover facility, and tonight I'm just going to talk to you a little bit. The presentation that I'm doing tonight is Health for the Hands That Feed Us, but it's really highlighting our migrant and seasonal farm worker program. But before I begin, I'd just like to acknowledge Dr. Stevens back here, who's our Chief Medical Officer at Westside. He came to support me, and my husband, Muhammad, came to support me, so I'm grateful for them, and Cindy for inviting me. Okay, I'm a little nervous, so I want to begin by just showing you a picture of the hands that feed us. Can you see them? It's not a mistake. The hands that feed us are often invisible. Hands are people who work in the shadows of a multi-billion-dollar industry without enjoying its rewards. This is a direct quote from The Human Cost of Food, a book called The Human Cost of Food, co-authored by Charles D. Thompson Jr. and Melinda Wiggins. And they both work for farm workers, so this is a quote from what their experience was working with the farm workers. So food for thought tonight. How many bites of any kind of food can you eat without it passing through the hands of the farm worker? A lot of times, both children and adults alike don't connect the dots. Children believe that food simply comes from the grocery store. And too often adults forget, too, that food has to be cultivated, harvested, and processed. We all like to eat, but we don't all know where it all comes from. So a little bit on the history. On September 25th, 1962, President John F. Kennedy signed the Migrant Act into law. This law was established to authorize both primary and supplemental health services for migrant farm workers. Since that time, a number of reauthorizations and acts have been passed to better serve our migrant farm workers and their family members. The Public Health Service Act is a federal law that was enacted in 1944 for the provision of health care services to special populations. 330H is a designation for the homeless population. 330I is a designation for those residing in public housing. And 330G is a designation for the migrant and seasonal agricultural workers. Westside Family Healthcare has been a 330 grantee for 26 years, which is a designation for a federally qualified health center. And Westside Family Healthcare has been a 330G grantee for the last 6 years. And this is a picture of our mobile health unit. When I'm explaining to people what it's like, I say that it's like a doctor's office on wheels. It's a really nice vehicle. It has 2 full exam rooms on there. It has a small lab, a little reception area. And we actually take this mobile health unit out to the fields where the farm workers work at and some of the farm labor housing where they live at. And we go out at least 3 to 4 times a week and provide services to them right on site.
Wow, that's great. That's great.
There are 3 categories for which a farm worker can be classified: a migratory worker, a seasonal worker, or age or disabled worker. So in order to receive these services through the 330G grant, you have to be eligible. If a farm worker moves to establish a temporary residency for to work in farm work, they're classified as a migratory worker. If the person lives in the area but they do the farm work on a part-time basis or intermittent basis, they're classified as a seasonal worker. Or if they reach the age of retirement or they become disabled during the course of working in farm work, then they're classified in the age/disabled category. So every time that a farm worker comes into one of our sites, or if we're out at a location, these are some of the questions that we ask them, not only the farm workers, but we ask every patient, because we're trying to make sure that we're capturing all the farm workers. So we ask them, have you ever worked in agriculture before? Or we might use the word farm worker because a lot of times the education level might not be that high. They might have like a 6th grade education. So we try to use words or terms that they're more familiar with. So we might say, have you ever worked in farm work before? Have you ever moved to work in farm work before? Is farm work your main source of employment? Or did you retire or did you become disabled while you were doing farm work? And that helps us to identify farm workers to determine whether or not they're eligible for it or not. In 2015, more than 250 health centers, consumer boards, clinical leaders, and farm worker advocates across the nation came together and issued a call to action. This call to action is to work collectively to develop more strategies to increase access to care for migrant and seasonal farm workers and their family members over the next 5 years. According to the statistics, only 18% of the estimated number of agricultural workers in the U.S. are being served by health centers. So at Westside, one of the things we've done, and we'll continue to do, is to train our staff on every time somebody comes in, we have a little slogan that we say, ask every patient, so that nobody will slip through the cracks. So we ask everybody, and we go through this series of questions to determine whether or not they are eligible for the services or not. So when the farm workers come in, just like when you come into any federally qualified health center, we have a sliding scale fee. And it's based on your household size and your income. So whether you're insured, uninsured, or whatever, we are always able to provide you the service regardless of your ability to pay. So we pride ourselves on that. And so a lot of times with the farm workers, because a lot of them don't work the full year, we look at their household income based on the time that they work, household size again, and then we put them on a sliding scale fee, and we don't turn anybody away. The agricultural workers that migrate up the East Coast migrant stream come to our program at Westside usually comes from the states of Florida, Georgia, North Carolina, and Texas primarily. We also have a couple of crews that come from Puerto Rico, Haiti, and Jamaica. The number of farm workers has decreased considerably over the years. In 1993, more than 6,000 migrant workers traveled to the state of Delaware to work. However, more recent statistics from the National Center for Farm Worker Health estimates just a little under 2,000 workers, which is still a lot of workers to provide health care for.
That's in the state of Delaware?
Just in the state of Delaware. Our migrant and seasonal agricultural worker outreach staff consists of a family nurse practitioner, a certified medical assistant / lab technician, our mobile health unit driver, a medical receptionist, 3 case managers, and myself, the director of rural health. And when we go out to the sites, to the fields, or to the labor camps, one of the reasons why we have a certified medical assistant / lab technician is because if the medical provider is ordering labs, if they don't get the labs, the service stops there because the doctor needs the labs to determine, what's wrong, how to better treat them or whatever. So because of that, we take a lab technician out with us. When we go out to the camps, we try to set up our the site exactly like we would have it in the healthcare center, and we mimic the same thing that we do in the healthcare center. We do it out in the field. As you see in this picture, this is the little reception area that we have outside the mobile health unit, and we're actually registering some of the farm workers on the outside. And we have them set up. We use our electronic medical records outside. When we're out in the field, we have access to it, and we put them on a schedule just like we would if they were coming to the health center. A lot of times we have to modify our schedule because of their work schedules. And although our team here consists of like 8 people, we get a lot of support. The Dover office team, they support us. All of the administration supports us, and also, the different disciplines within Westside support what we're doing out on the field with the migrant and seasonal farm workers. I'm really passionate about it, but also the other employees are just as, the other staff members are just as passionate as I am about it. So. Let me mention too that when we go out, because of the language differences in languages, we have staff that speak the language of the population that we serve. So we have a few people that speak Creole, people that speak Spanish, English, and we had last year one person that actually spoke Patois so he could communicate with the people that came from Jamaica. So our season usually starts around April through October. Although farm workers arrive as early as February, some of them are already here now, but the peak season is in July. We have estimated farm workers between 1,500 and 1,900 that come. And once they get here, what we do is we take our case managers and we go camp by camp and we do a camp census to find out who's here. And that's important because if we're going to treat them, we do other things other than the medical service. In addition to the medical service, we do a lot of support services as well. So we go out and we try to see who's on the camp, if it's men, if it's women, if it's children, so we can know how we can best work with them. We do a needs assessment on each individual that we register, and we ask it's a medical needs assessment as well as a social service needs assessment. And also the case managers, one of the things that the case managers do in providing supportive services is that they provide transportation. Like some of the people might come up from Florida on a bus. So, if you got a doctor's appointment, if you have to go to specialty care or something like that, you can't take the bus for one person. So we usually do a lot of transports to specialty care. We take them to the pharmacy. We provide pharmacy assistance for them, translation services. We do HIV testing and counseling with them. Our case managers do that. We do TB assessments through quantiferon, and if they have a positive one, our case managers actually provide a DOT for them to direct observation therapy for them. We go out to the fields, we take them the meds, and we actually watch them take the meds. And it works out pretty well because sometimes if a health care worker for public health goes out, they go out in a state car, and so it's kind of like alerts everybody. So when we go out, they're used to us coming out, and it's a little bit more private when we go out. And we know the workers because we've developed a relationship with them. As I said earlier, we go out 3 to 4 evenings a week. Depends on the weather, Monday through Thursday, beginning in July. Because some of them have already started coming in February, we will start probably in May. We'll be picking them up and bringing them into the health center. And then in July, we'll actually take the mobile health unit out to where they're at. And we serve all of Kent County and western Sussex County. And so when we go out, we go to all of Kent County and western Sussex County. And so sometimes it could be a long day. If we're starting all the way down, bringing people up to come to the health center. So it is really a good thing that we have the mobile health unit so we can take the mobile health unit right to where they're at. And it's also good because we don't want to impede on the farmers' time. They come here to the state to work. So that's their primary focus. So we try to make sure that we go out in the evenings. We stay 5, but we work around the schedule of the farmer all the time and the crew leaders because we want to be welcomed on the farm. So we try to work around that. And we say we're going to stop at 9. We hardly ever stop at 9. Dr. Stevens can tell you that. We won't turn anybody away. We have stayed till 2, 3 o'clock in the morning waiting on patients because usually when they come to us, it's like acute. It's like they've done everything they can do to try to work it out on their own. And so they're ready for the service by the time they get us. Same thing with the dental services. Usually the people that we bring in for dental services, because we actually pick them up and bring them into our Dover site, they're going to have a tooth extraction, usually, because they wait so long to get dental care. And so we see all kinds of different medical conditions, and I'll discuss that a little bit later. So some of the faces and the statuses of the farmers has changed for the last couple of years and may continue to change in 2017 and beyond. It's just depending a little bit on the climate that we are actually in. But I did it again. I'm sorry, Cindy. I'm used to just talking about my program, not having papers in my hand, but I want to make sure that I'm covering everything. Yes. So I was just saying that in the past couple of years, the faces and status of the farmers have changed and may continue to change in 2017 and beyond. Over the past several years, we've been seeing fewer and fewer women and children traveling up the East Coast migrant stream. Women are electing to stay home with their children, to do seasonal farm work or domestic work in their home states rather than to migrate with their spouses. So there's another challenge for the men when they come up. They're separated from their families, and then the women that are staying back home are separated from their husbands and their children. So sometimes that poses a problem or a challenge for them. We're seeing fewer and fewer seasonal farm workers, but we're seeing more HTA workers, and I'll explain. So an HTA worker is the H-2A program is a federal program that allows U.S. employers or U.S. agents who meet specific regulatory requirements to bring foreign nationals to the United States to fill temporary agricultural jobs. And I just want to explain how that works with the next slide. So what happens is the farmer or the crew leader can apply for a submit a work order to have people to come from other countries to work in our country. But the process is they must first reach out to the people that are in their local state, their local communities, to see if they want those jobs before they can put the work order out there. And after they've done it and proven that to the Department of Labor, that's when they can get the labor certificate. Once they have the labor certificate, they have to submit a Form I-129, which is a petition to bring a non-immigrant into the country. And then the third step is that the farm worker themselves has to apply for a visa through their embassy or their consulate's office. And once that's approved, then they can come in. And when they come in, there's very strict rules around them. They can only stay in the country for so long. They have to be working. The farmers have to provide them with a place to stay. They have to, there's a lot of regulatory requirements around that. So we've been seeing more and more of that in the state of Delaware. So one of the main crops in Kent County is potatoes. There are lots of potatoes in Kent County. I think every farm, but that we serve 10 farms. It has 9, but we do 10 now in Kent County, and I believe all of them now, except for 2, are potato farms. So Delaware produces anywhere from 4,000 to 5,000 acres of potatoes annually. So that's a lot of potatoes. Mm-hmm. This is some of the housing for the farm workers. This is some of the housing that the farm workers stay in. And if you've ever looked at a film with migrant farm worker housing from 20 years ago, it kind of looks the same as it does today. Last year, there was a special grant that came out, and one of our partners, we have a migrant and seasonal agriculture workers advisory board, and one of our partners is Tom Corporation, and they actually worked with a couple of the local farmers to renovate some of the farm worker housing, and they actually put in central air in a couple of units, so the farm workers were really appreciative of that this past year. And in Sussex County, they mostly, most of the farm workers that we work with harvest watermelons. And there's a lot of watermelons, a lot that comes out of the state of Delaware. Women in Delaware together produces more than 325 billion pounds of watermelon a year. So, it's a big thing. I don't think people, unless they get into it, really realize how big it is. But a lot of the times you go in the store, you see those big cardboard boxes with the watermelons in. A lot of times they're coming right from the state of Delaware. So they have a watermelon queen, they have a watermelon festival between the 2 states. So it's really big. And down in Sussex County, they have what they call the Laurel Auction Block. And at the Laurel Auction Block, it has probably 10 platforms on it. You'll see the buses. I don't know if you've ever seen the buses come that has all the windows cut out. And it's just the bottom of the bus, and it's loaded with watermelons. So they go out to the fields, and the men hand-pick the watermelons, and they throw them from one person to the next till they get into the bus. And they put it on the bus. They drive the bus into the auction block. And at the auction block, they have about 10 platforms where they actually grade the watermelons, depending on their size, what kind they are, and all that. And it's really interesting to see, and it's been there for a long, long time. And probably you've never heard of the Laurel Auction Block, but it's in Laurel, Delaware. And anybody can go on there, but that's where they actually auction off the watermelons wholesale to wholesalers. And in Sussex County, because the farm worker housing is limited, a lot of the farm workers stay in motels. And these are the motels, some of the motels that's listed where we go and find them. We've established relationships with the owners so that they give us permission to come on site. So we go to the motel and we do the same thing. We register people that are registered farm workers if they haven't been registered already. And we provide health care services right there on site for them. And these are some of the people that we work with. You can find as many as 8 and 10 in a farm worker household sometime. And that can be a challenge in and of itself. So last year, we did a student engagement project. We worked with Delaware University and also Harris Business School. And we brought on, I think it was about 8 volunteer students. They came in and they worked with us out in the field registering patients. They did learn how to do point-of-care testing as well. they shadowed our provider on the mobile health unit. So these are just some pictures to show you what we did. In addition to that, we also partnered with Southern Jersey Center, Family Medical Center, which is just across the Delaware line. And they came down for a day and spent the day with us and helped us to service the farm workers in our area. And we spent the day with them to help them work with the farm workers in their area. And I tell you, it's a good experience for us because you can kind of gauge how you're doing things based on how they're doing things, what their population is like. And I didn't realize that there were so many blackberries in the state of New Jersey, but they have loads and loads of blackberries. And one camp, I think we went on, had 500 farm workers on one camp alone that was there to work in blackberries. In 2017, we will be focusing on Ag 2020 as the campaign that I mentioned earlier, where all the people that provide services for the farm workers were working together to increase access to care to the farm workers and their families. And then we have certain clinical measures that we will be working on, and one of them will be the clinical measures that we'll be working on. We will continue to do HIV testing and counseling. We will do the quantiferin testing for TB assessments. We do a behavioral health assessment, and we do HIV testing and counseling, and we'll be monitoring the PAPs as well. Those are just some of the things that we'll be focusing on, and expanding our outreach services. I'm sure that I left out a lot of things, so does anybody have any questions? Okay.
So for the farm workers who are coming back seasonally each year, do you find that you have a lot of the same people that you're developing long-term relationships with?
Up until the last couple of years, we could count on the people that were coming back because it's like a generational thing. The grandmother came, the great-grandmother came, and you would see them over and over again. In the last 2 years, it's kind of been changing up a little bit. I think some of them are getting older. They're opting to stay home, and then there are a few that are opting to work in their home state. But they usually typically still do the same kind of work even when they stay in the state where they come from.
And for those who you do develop kind of a long-term relationship with, are you kind of functioning also as like a primary care provider, doing like basic screening and health maintenance?
We do primary care when they come to us, and also we connect them so that when they go to the next state, they have access to their records. We work with a network called Migrant Clinicians Network. And so when the farm worker goes to another state, if they want to have access to their records, of course they can get them from us and carry them with them. But they sign an agreement. We will give their information to Migrant Clinicians Network, and regardless of where they are, they can access it. Even people outside the country get resources to access their medical records. And it's very important because when you're going from state to state to state, and you get to one doctor and they have to start all over again from square one, they don't have your medical record. It's very costly and it's very time-consuming. And with this population, they're very transit, and they have a very short limit of time that they can get services, because by the time you get them work started, they're moved on to somewhere else. So that's great.
Do you know why, or do you have any idea why you think the women and children aren't coming anymore? Is it cost of living, continuity for the kids?
I think it's probably a combination of all those things.
Okay.
Do you find, are you able to teach and like preventative medicine, for instance, high blood pressure or hypertension or TB prevention, if that's, or HIV?
So as a provider at Westside Family Healthcare, one of the things they do is they do provide education, not only for the migrant seasonal farm workers, but for all their patients. And in addition to that, we do have like the certified diabetes educators that they will talk to. We have a certified nutritionist. We actually take her out to the camp sometimes with us. They will meet with small groups of people. They will meet with them individually. One year a couple of years ago, we took our nutritionist out to one camp, and I was really surprised at how she was received, because I was thinking in my head, we're going to set this up, but they're not going to show up. But one good thing is, if you go where they live, they can't really leave. It requires transportation, so they had to stay. But they wanted to stay. And at this particular camp, they were primarily people from Haiti. So we had a translator. So we had somebody say it in English, then somebody to say it in Creole. But they sat there the entire time. We had a group of about 20, 25 people. And she actually did a demonstration and showed them how to prepare a little nutritionist snack. And it was so important for this particular camp because the motel that they were staying in, they didn't have stoves, and some of them didn't have microwaves, and they were actually cooking on grills. So if you can prepare something that doesn't require cooking, that was like, and some of them actually said that they went to want those same things that she showed them, and they tried to do it on their own. So there are opportunities for teaching them, and we do our case managers do things like we teach hygiene, hand hygiene. We teach them about sun exposure, things like that will help them while they're out in the field.
Sorry, Ms. Roughly how long are they here in Delaware?
So it depends on what crop they're doing.
Yeah.
So like if they come to do watermelons, they're usually here in 3 to 4 months.
Okay.
If they come, some of the farmers have multiple crops, so they might have potatoes, they might have cabbage, they might have green beans, but some stay as long as like 6 to 8 months.
Wow. So related to that is chronic conditions when it's a long-term thing and whether it's diabetes, etc., and also psychosocial behavioral health. But sort of the issue is you're not going to see them very too long. How do you address not only acute things, but what do you do to help carry on? If they're going to go to another state, you're not going to probably see them again until next year. How does that work as far as?
So I'm going to try to answer the best I can, and Dr. Stevens, you can jump in if you like. But the way that we handle it is that, of course, we try to provide as much education as we can for them. We help them with medical supplies. We help them with medications. We have different pharmaceutical programs that we work with to help them get their medicines at a reduced cost or sometimes for free. And then we have specialty care. We connect them with specialty care while they're here in the state of Delaware. But we also have a network with other migrant health centers. So if we know where they're going at ahead of time, we encourage them to sign up with Migrant Clinicians Network so that their records can be transferred. When they go, they can have their access to their records. And we can tell them what state, if they say what state they're going in, we can look in the directory and tell them, well, this is a migrant center located here, or this is a regular federally qualified community health center. And we have a lot of things that's similar from state to state. So if they go to another state, they can be placed on the sliding scale fee so the care is still affordable to them. So I don't know if you want to add something, Dr. Stevens.
I don't need to. That was a fabulous answer.
Okay.
And the psychosocial, or do you see any issues that they may not be long enough, but behavioral issues that
We
need
do
to be
see
addressed?
some. With this population, of course, they're isolated a lot. They're away from their families. Not only are they away from their families, but they're away from the local communities, because most of these farm labor camps are sitting on back roads away from people. Like, they're not next to a store or anything like that. And so with that, a provider usually will work with our referrals coordinator to refer them out for specialty care, like somebody in behavioral health, to work along with them. We do a behavioral health assessment as well.
So I'm sorry for all these questions. How many days do they work? 6 days a week? Or how many days do they
Some
work?
of them 6 and some of them 7 days a week.
Because my next question was about recreation, spiritual issues, and help. Just having a regular life instead of basically a 7-day work for months.
Right. Well, from my experience of working with them, and I've been working directly with the farm workers for the last 14 years, it's not regular or normal for us, but it's regular and normal for them. Some of them, like we have one camp, the more they come, like if they come on a more consistent basis, you kind of learn the community. So some of them will branch out and go to maybe a church or some place where they can, worship God or whatever they choose to do, but we don't see that too much. So I don't know if I answered your question.
Yeah, now you can see what I was trying to get at is just
Yeah.
other things besides work in their lives while they're here.
Well, we see a lot of behaviors as a result of them being isolated. Like you may see on some camps where they're constantly drinking.
Yeah.
They may be smoking, So we see some of those behaviors because of what they're dealing with,
Well, Sharita, I think that, when we first started doing this, we actually applied for this federal grant and really didn't know what we were doing. And we had a steep learning curve. Fortunately, we found Sharita, who had already been doing this down there, but we still had a steep learning curve. There was an awful lot to learn. And I think the one thing that really shocked me, still distresses me, is in a lot of ways how close what goes on in the agricultural world is to slavery. It really, the folks there, the reason that we have to take them, the bus out to them in the fields, is because they can't leave their job during the middle of the workday or they won't have their job. we accommodate the schedule to make sure that we're able to take that care to them. But it's still not a great system. One of the things that, and that was, I think, really hard for me to stomach when we first started doing this, because, my first instinct was, let's push back, let's change the system, social justice, all those sorts of things, but realized that if we were going to be effective at providing them health care, we had to earn the trust of the farm owners. We had to earn the trust of the crew leaders. So I think that one of the things that I see as our mission is not just to provide that health care, but to do it in ways that don't jeopardize our ability to do it, but on the flip side, to educate people about this. And that's why I think when Sharita gets, out here and speaks to folks, I think it's so crucial that people hear about this entire industry that really is on the backs of a lot of people that don't have a lot of rights and don't have a lot of opportunities, so that hopefully someday this is not the way that agricultural work occurs.
Are there labor laws that are protecting them?
Sharita, you know the laws better.
There are labor laws that protect them. We work a little bit with the Department of Labor. They regulate their housing, they regulate the work hours. They also, the Department of Labor has the division of wage, wage, your earnings and all of that. So they work, but they kind of work in the shadows, because if you, if you're on the wrong side of the farmer, it kind of just it stops things. So we work together, but they kind of work in the shadows. So like, if somebody asks us for the information, we might share a name with them or whatever, or trying to point them in the right direction. But so our main purpose is to provide the help, and we will help, but we usually take our lead from the farm worker themselves.
I agree with you, and it's really tough because you don't want to be taking away their revenue and their livelihood. Do you know if they make? Speaking of the wage issue, do they make this? If most states have minimum wages, do they make the minimum wage?
They do make the minimum wage.
So that's basically so it varies by state then.
Yeah, it does. And actually, I met with someone from the Department of Labor 2 weeks ago, last week actually. So on the whole, yes, they do. You may have somebody here and there that may try to get over, and I think that's every state. You'll find that. So, but there are people that work to help the farm workers. If they reach out to them, they will help them.
So, what are the most frequent issues that you see in the farm work?
With reference to medical conditions, some of the same things that we see with the regular community, like diabetes, high blood pressure, high cholesterol.
Yeah, but then there are some things that are, and I don't know that we really see them that often, but there are things that are more specific to agricultural worker populations, as far as exposure, heat exposure, exposure to pesticides. But we've, I think, been fortunate that we've not seen a lot of that. It really does tend to still be the obesity-related diseases, the diabetes, hypertension, a lot of the chronic conditions we see all the time anyway.
Back pain.
Mm-hmm.
At the watermelon farms, there's a lot of that.
If I could I read you?
Excuse me, I came late because I was trying to find out this book.
It's hard to find.
I was interested in listening to your talk because we have seen this. I am from Guatemala, and people migrate from the mountains to the coast, and they go for the time of the crop, and they work there, and they are taken back to the mountains in trucks, like cows there, sometimes they go. And the farmers, whoever the owners, have very, very poor conditions for them. There was a Prize Nobel for the peace that used to work that way, but anyway, they was from Guatemala. And the reason I was coming here because my daughter got a master in public health, and she used to go to this area in New Jersey and Kennett Square to work with them. Then she decided to become a doctor because of that. So she's a doctor now. She's working here, but she's a surgeon. But I was interested in seeing what can be helped, what can we do? Here I am a retired neurosurgeon, so I don't know what can I do, but I am a doctor anyway. But I was wondering if we are a lot of people retired that we would like to help with these people. Even like physician assistants to somebody like if I work under your responsibility or whatever, and I can see many people, and particularly the people, in my case, people that come from Mexico, or from Honduras, or Central America, Mexico, I can speak to them in.
Have your translator.
Let me mention one thing that's recently happened that I think is exciting that may help us in that respect is up until this past year, health centers couldn't employ volunteers at all in direct patient care because of malpractice insurance. The federal government recently changed that. So now the malpractice insurance coverage that provides coverage for health centers is eligible for volunteers. And I anticipate that that's going to open up a lot of opportunities because you're certainly not the first person I've heard that has these qualifications, would love to give back and participate in the care of these populations. And now we may have an avenue to do that at. We're still waiting so the law passed, but the regulations, the operationalization of that has not yet happened. So we're waiting on that. So that may be an opportunity for folks to then participate. And we're certainly going to be looking at that if there are ways that folks
could. Even though like that, I have my license still.
Mm-hmm.
I can work. I don't do it as a neurosurgeon, but a physician. Sure. I did the emergency rooms also. So I feel myself like I'm a doctor still, and I can treat hypertension, diabetes, and many things.
Sure.
Because I decided not to. I will decide to treat my patients, even if there are neurosurgical problems. I will try to work with the medical problems that they have. So it's true that everything changes, and the population, this type of population, is very ignorant in general. It's difficult to deal with them. So I mean, as a doctor, you say, well, take this, and unfortunately, in many cases, you give a prescription, but they never fill because they have no money. If you get the medicine, sometimes they take it, sometimes they don't. So where is the people coming from in this?
So we do see some farm workers in Sussex County from Guatemala.
Yes.
We see a lot. Between Kent County and Sussex County is kind of like really different. Like in Sussex County, we see people from everywhere. As I mentioned, we see them from Haiti, we see them from Jamaica, Guatemala, we see some from El Salvador, we see some from Mexico, and in Kent County, we pretty much have people from Mexico, Puerto Rico, and African Americans in Kent County, kind of divided 50-50 between the African American population and the Latino population in Kent County. And the difference between the two counties is almost like night and day. The housing for the farm workers is primarily in Kent County, and in Sussex County, people usually work underneath the crew leader, even if they won't tell you they're working underneath the crew leader, and that they kind of have to fend for themselves when it comes to housing. One thing that we sometimes they want to be compliant, but the conditions don't allow them to be compliant. For example, you gave a good example about if you give them a prescription for medication if they don't have the money. But we do have case managers that will work with them to help them get their meds that they need. We work with a couple of pharmacies, a lot of pharmaceutical companies that are trying to help them get the meds that they need. We have one camp in Kent County that provides food for their workers. but they provide 3 meals a day. They provide breakfast, lunch, and dinner. But it's the same for everybody. So if you're on a special diet, you still have to eat that food. Or if you don't eat the food, you still have to pay for it because it's taken out of your wages.
Oh.
So they want to be compliant on one hand, but on the other hand, so they got all of these other things that they have to take in consideration. Another camp that we had in Kent County, we went there and we were all had our chests all stuck out because we knew the people that came were from Mexico. So we took our Spanish speaker case managers out there. We got out there and we're talking in there and we're looking at us like we were crazy because they spoke a different language. It was a deeper dialect. They spoke a language called Tzotzil. And so we had to translate. The translation had to occur a couple of times. So somebody spoke it in English. The English speaker spoke to the person that spoke Spanish. Spanish person spoke to somebody that actually did speak Tzotzil. We had to use the language line as well at first until we figured out that somebody on the camp did actually speak that language. But we utilize the language line for people that have a language that we don't have a case manager that speak that language. We utilize the language line for that. So those are kind of some of the things that we do run into.
It is difficult in Guatemala. These people was displaced during the Civil War in Guatemala. They are next to Mexico. Mm-hmm. So it's easy to say, well, I'm in Mexico, so I go to the United States or whatever. So many people were displaced that way. So there is a group of Indians, the Quiche Indians, the Maya Indians, that they speak one town, speak one language, and the other they speak another one, and they don't communicate each other. They communicate with broken Spanish, and so they never learn the language. So and then they're displaced, and so people started to understand things, but it's very difficult for them to adjust to this situation. The other problem is that they want to go back to their country, Mexico, Honduras, whatever, Guatemala. They want to go once in a while and come back. They want just to make some money, and it doesn't matter working 24 hours a day or it's impossible. But anyway, it's just every day it doesn't matter. If they work hard for 3 months and they took some money back, that's helped significantly for a year.
That's true. I think you said how migratory the patient population is, but how do you manage the follow-up of patients in that maybe short 3-month time that you are seeing? Do you see many patients back for a second, third visit? How do you do lab follow-up?
So what we do is, like, when they come in to see the provider, if the provider needs to see them back in 2 weeks, the case manager follows along with them and make sure that they have an appointment to try to get back on the mobile health unit, or we'll bring them back in 2 weeks. If they have labs that need to be done, like I said, we take a lab tech out with us. They'll draw the blood or whatever, and then we'll set up the appointment so that when the lab results are back, we'll bring them back in to go for it. And we do have quite a number of people that will have more than one visit, so it's not like a one-time thing. If we get them in there, we can talk to them and educate them and teach them about preventative care. They will come back. And so a lot of them that's been coming over the years, they know what Westside is. When they get there, they'll start calling us on our cell phone and let us know that they're in the state of Delaware. They need an appointment for whatever. So it's a good experience.
So in California, we're looking for a number of undocumented farm workers. Is that something you see out here, and are they eligible for care as well?
We do see some, but not a lot. And we don't ask and we don't tell. So our primary goal is to provide health care. There's very rarely we would need to know that information. I'm going to give you an example where we would need to know it. If somebody came to us and they needed something they needed a lot of hospital care, or they needed something that was way out of the scope of what we could do, or they needed like a hospital stay or a surgery or something like that, then if they are coming from like Florida or whatever, we might ask them if they have a social security number or if they're documented, because if they can get Medicaid, then that will help take care of that. But we do work also with the hospitals to help them get some charity care. But usually it's for people that's documented. So that's the only instance that we would want to know the information, is to help them access other services in the state where they're at. That's the only instance that I can think of that we really need to know that.
And Sharita, let me just point out one thing. So you're absolutely right that we don't ask and don't tell, but it's not in the sense that we're supposed to be. As a health center, we're actually what's called a safe harbor. So it means that we are not required to ask that information, that we are specifically supposed to be a safe place for anyone to be able to come regardless of their immigration status.
Can I ask, is that,
Sure.
It's not because of being an FQHC, it's because of having this particular program?
No, it is.
Or it is because of
it is
FQHC?
It's as an FQHC. Our
Great.
entire population, that's the
Great.
case.
That's great to hear.
If I could, I just want to give you two little brief stories. Our CEO, which is Lolita Lopez, asked the Farm Worker Program to put together little stories each Friday. We call it Farm Worker Friday. And the reason why we do it, we put the stories together and we shared it with our staff because we wanted to keep the farm workers on their mind. And we wanted everybody to have an understanding of what the challenges and barriers and the different medical conditions that these patients face. So I want to read just two of them if you don't mind. It says, today we're sharing an example which highlights the barriers that our farm workers face when they're trying to improve their health. Despite the fact that they pick healthy foods for us to eat, they don't have access to the same healthy foods. Thanks to nurse practitioner Ola Afalaka, who's one of our providers, for sharing this story with us today, and happy Farm Worker Friday. This season we have been caring for a farm worker patient who has been migrated to Kent County to work on a local farm for the last 7 to 8 years. She is 52 years old with uncontrolled diabetes. Her blood glucose levels were in the 550 plus range, extremely high and signaling a dangerous and out of control diabetes situation. And after insulin and treatment by a nurse practitioner, they fell to 507, 297, and 197 at fasting. She has also been diagnosed with hyperlipidemia, hypertension, hypothyroidism. This patient was recently sent to the ER with a diagnosis of anemia due to a high salt intake and prolonged hours of standing. The latter is a requirement of her job. At first glance, one would assume that this patient is non-compliant, and she is, but not by choice. At this particular camp, the farm workers eat corporate meals, meaning that all meals are prepared the same for everyone without regard to dietary needs and or restrictions. Farm workers are charged for these meals whether they choose to eat them or not, and monies are deducted from their pay, $50 per week, which is not a lot of money, but if you got to pay for something that you're not eating, it is. They receive 3 meals per day, which usually consists of breakfast, ham and cheese on white bread, coffee, and or milk. Lunch is rice, beans, and sometimes fried meat, chicken or pork. And dinner, rice, beans, fried plantain, and some of the fried meat, the chicken or pork, sometimes it's the same thing as what they had for lunch. Although this farm produces cabbage, corn, and green beans, we have never observed these vegetables being served to its workers. If a worker misses a meal because they're not on site at the time the meals are served, they're responsible for finding their own other means of eating. So our team continues to work with this patient to provide care and case management for our chronic diseases, as well as education and referrals to resources for social support and improved nutrition. So that's just one of our patients. And this other one, I want to read this one. On August the 22nd, the Farm Worker Health Outreach Team traveled to the Country Health Inn in Sussex County, where many migrant workers live temporarily during the season. Our case manager completed a health and social service assessment for a 40-year-old Creole-speaking male. The man told our staff that he did have some health concerns, as his legs and stomach was swollen, and he was not able to eat or sleep. The team determined that this man required immediate care, and because the mobile health unit, which was undergoing repairs at the time, was not scheduled to go back out on the road until the following week, this man will need to be transported to the Dover Health Center first thing in the morning, or for the appointment with the provider. The patient was picked up the next morning by our team, as he did not have access to transportation, and was seen in our office by one of our nurse practitioners. She provided him with a lab and diagnostic orders, but because he could not obtain CHAP, it's not CHAP any longer, enrollment, due to his residency issues and the dire nature of his condition, he was taken to Bay Health Emergency Department. The patient was admitted to the hospital that day, and the next day was transferred to intensive care because of his condition had worsened. A few days later, the patient was stabilized and received the following diagnosis. And I don't know if I can even read this. Dr. Stevens, can you help me? These words are a little bit much for me. I don't know if you can help me. I could try, but you might not know what I'm talking about. Starting right there.
Thyrotoxicosis. CHF, congestive heart failure, hypoglycemia, atrial fibrillation, elevated alkaline phosphatase, and other liver enzymes, hyperkalemia, acute renal insufficiency, and anion gap metabolic acidosis.
Wow.
So,
Sick puppy.
yes. This particular, he did. But they did tell us that we hadn't got him there when he came in, that he wouldn't. The outreach team members, we took turns going back and forth to the hospital to check on this patient, as he had no family here in the United States. And his roommates, this was kind of bad. His roommates, there was about 8 or 10 of them staying in one room, and he was so sick till when he couldn't work. One of the roommates was trying to do his work, and the other man that was sick was work. But when it got too much for him, so they could both still get the pay, and he could pay his portion of the room rent, because the room rent is not reduced; it's still pretty high for them. So they have to stay like that in order to make something if they got paid for the room. So, but when he got so sick that and the gentleman couldn't help him any longer, he was actually laying outside of the room on the balcony because the other workers didn't want him in the room with them. And they had a problem with him because they thought he had paperwork and they didn't have it, so they had like a little bias against him. But this gentleman was so thankful for us for taking him to the hospital. He stays in contact with us. He was determined to be permanently disabled, but he does reside in Florida, and he does have his paperwork. But he does call us every now and then just to say thank you. So those are the kinds of things that we run into. We had another mother that we have been working with for a few years. She had a serious condition. She had to get a trach. She had a baby. She was severely obese, and she just had a whole lot of medical conditions. But she did give birth to a baby, and then 2 years later, she gave birth to a set of twins. Okay. And then last year, one of the twins actually died while they were out on the camp with us. So we encounter all kinds of things with working with the migrant and seasonal farm workers. So that's just a couple of the stories. But we did a story every Friday just to keep them on the minds and hearts of the people, the staff members that were actually working with them.
Something like that, will you help them with grief, like going the grieving process?
We will work with our referrals coordinator to make sure that because she really did need it. And we actually attended the ceremony for the baby. They actually had a ceremony. Our case managers, our outreach team actually went because we provide comprehensive services. And a lot of these people, they've been coming year after year, and so they know us and we know them. They tease me a little bit. They tell me sometimes that I'm the mother of the group. So some of them call me their mom. But even though we have boundaries that we establish, you do develop a relationship with them, and you really care about them, So.
Thank you.
Thank you for having me.
Thank you, Sharita, and thank you all for coming.
Thank you.
For the next email next month.
Thank you.
Yeah. I pretty much every day. I will.
It'll be that one specialist that tags along. You can any narrow problems, I guess. If any of you understand what you're
Didn't I see you recently at you were just a global level? At Jerry.
How are you?
No, down here. Were you down here recently? I don't remember.
Years and years.
How long ago? Anyway, I try to get here when I can. I don't know much. Yeah, when I spend time and I ask about hear about this.
This room is so hard.
No.
I know.
Yeah. They say hi. How long ago? 7 years. Oh, that's great.
It's even.
Chris is still there?
Yeah.
I stole his office.
When I moved, or when I started there, they had just moved into the office administrative offices that they have down by the riverfront.
Okay, see, I haven't even seen that.
Okay. Yeah, so it's a building that used to be one of the shipbuilding administrative offices and neat historic building. Anyway, we had just moved into it. That's the headquarters of the whole organization. We've got a couple administrative buildings.
Well, I think it's on the mission trip.
And when I moved in, everybody else already had an office, so I got this other one. Well, just recently, we mixed everything up. My office needed to be bigger because we needed the conference space in my office, and so I hit Chris because I really
Chris,
stole his
when you
office.
see Chris, and say,
I will.
Tell him I've said hello. I met his wife.
Yeah. Well, so my wife is a Jeff grad. So she's family medicine.
Right. That's wonderful.
Very sharp.
Oh yeah.
You know, and when you
Well, she's doing now. So she is.
When you're away from it, you're not there
She
all the time. You
actually
don't get to be around colleagues
went
and
down
talk
to
about all
North
these
Carolina and
interesting
did an
cases. Or you
educational
just have
fellowship
you know, it's like,
Chapel Hill.
Wonderful.
She and I met because I was.
Here?
No, we met actually in Western North Carolina. I was working in a rural community there as a family doc, and she came out as part of the fellowship to meet somebody. We met, one thing led to another, long distance dating and all that. She grew up outside of, in Freehold, New Jersey. Went to Jeff, and so after we met and all, we decided to move back up here to
How long ago, if I can ask you, Jeff, because I'll share that knowledge.
let me think. When was
It was
that?
a long time ago. It was more than 15 years ago.
No, it wasn't. No. Your colleagues should know her. She was Mary Maniscalco. Yeah. So now she is. So now she is. Here, I'll write on the first. You've got a.
Yeah, I do have his card, yeah.
I do want to be in here.
Yeah, that's great. I will share it.
Yeah.
Share it.
Yeah. No, she's.
Well, if you have a security Madonna like this one, you call auto.
Right.
You know,
So anyway, she went and did the faculty fellowship. Has been on faculty here at Christiana. Since we moved here. She ended up moving out of, she was doing a lot of med school teaching, and then moved into running the place.
Well, that's the reason why I remember in Delaware when I was staying at my parents' house.
Are there any opportunities? Because I'm thinking of
Yes.
you're saying a lot of
It has. So she's
Well, you learn a lot and you know a lot. You know, a lot of the trauma has
6 years ago, had a little Down syndrome, and so she's gotten very involved in that. Is really working on sort of national prominence now. And a year ago,
once a year.
Yeah, so he just retired, but before he retired, she
See, that's the thing. Exactly.
so all those get to the transition out
No,
of
I
being
totally agree.
now have a place to go. Yeah, so she's doing that.
That is because they don't have a choice because of all the things that we were trained that way. You look at the person, you look at, you don't talk to them. Yeah, you palpate.
I don't remember what her graduation year is, but too many Mary Manscalco.
I can keep you in the loop, please.
That would be great.
Yeah, it's a pleasure meeting you too, Ron. Thank you.
That is the way.
I know it's
But I don't know whether
Just see it. see the
Saturday.
What are you doing?
I'm starting positions. I like it. I work in the lab
and I love it.
I'm from California.
Arcadia University.
Oh, good. You did say. So
Yeah.
how far away is that?
Actually going to the
Where were
it's like
you?
right next door. Yeah. So
That's perfect.
it's pretty cool.
That's great.
Direction is called Bay. Go
Well, that's right. So I was going to ask you, why did you not want to be a nurse
literally
practitioner?
ran right into the team.
Just based on those
Well, I did the packet, the lab.
Yeah,
So I wasn't a
my
nurse.
sister
I was one of
lived
my
down in
nurses
Northern
for whatever
California
reason.
for about Davis.
So I had my lab background.
There was another one.
So, and he's right, but then sometimes, like, I've met a lot of physicians assistants. So this is good. And they have really interesting jobs. I met one in the clinic who was orthopedic PA, and he was in the OR part of the time and in the clinic part of the time with the doctor. And then I met two guys from the ER who were PAs, Patrick and Patrick was
I didn't have to
cool.
twist it
They
around.
liked that. And then I met
Yes, he came from there.
Switch specialties too whenever you want.
well, you can. All you have to do is get trained and certified, and then you can do it. If you do cardiology for 5 years, you say, "Yeah, I don't want to do this anymore," and do
Right.
something else.
Yeah.
Which is great.
planning.
Okay.
Oh wow, that's great.
Right.
Did he like it?
Well, he's not.
But it's a cool program. So if you're
I got burnt out in the ER.
at weekend,
Yeah,
A lot of
that-
people do that. They start in the ER.
If I make enough there, I want to make it further west and get to San Francisco.
well, you want to do that anyway.
Yeah, exactly.
But David, it's amazing how you think of it. Because Davis was
Yeah.
out of nowhere and it was known for its dentist school, vet school, but that is
Okay.
Okay, see, so now he's doing something.
Well, that's actually why they
you never know.
Right, yeah.
Could lead you anywhere. But you know what?
For personal reasons, things work out, but only occasionally maybe.
Right.
Yeah, you see, Rob.
And I told my son, I said, you'll never have a donor.
Yeah, we're
If
so
you go into
lucky.
medicine
I'm
school,
so glad you
you're always going to find, and you can
Yeah.
switch around if you get sick of it or you're burned out. You're always going to have a job that you love.
at the lab.
I mean, every year we learn something new.
But everybody who worked in medicine should work very hard.
Yeah.
Rita, this was awesome.
Do you like it because it's quiet?
I gotta meet your hubby. Hey, Tom Stevens. Congratulations.
How long have you been with us? I
If
go
you
back.
find something and say,
I left the note with
Right,
Lolita. I
right,
can't
right.
believe Lolita's not retired. I can't She's been
I keep trying to push her out.
oh, that's true.
I've only been there going on 7 years.
Well, that's still that's a long time in this program.
You
Is
know what I mean?
I
The
think it's
hardest
wonderful
thing
the
I
service you're doing.
Thank you.
I know here. We live in the Kennett Square area, so we
Okay.
deal with
The mushroom farm.
mushroom workers a lot and stuff like that.
Okay.
It's such important work and
Thank you.
really helping people. Basic stuff that they need.
Right.
And we all think, gee, I wish we could change
It was
things.
the patient.
I just hope they don't. I know with mushroom,
Yeah,
a lot of them give it a off, and I just hope that isn't the case too much with mine. And I know you can't control that. Those extras will probably see that
We make
stuff.
as big an impact as we
As you
can.
possibly can. Given the environment. So thank you for
All right, thank you.
wonderful stories.
All right, Dr.
Yeah, I'm actually going to head out with you.
Okay.
I've got to get back to the family and fix some dinner.
You'll remember it when you get outside.
So then,
So, Cynthia, you going to have
it's
Dennis
a
here?
disco for fact.
Oh, fantastic. But I don't know. I don't think you were copied on the email, but I was. An email.
Sure.
Inspiration.
All of the medicine residents out there.
For some reason, she
Aw.
to her talking, and my brother was also there.
Yeah.
So anyway, she said, Tim came and I was talking words that I used them.
But that's why I was trying to get it sitting up on
And then she
Oh, yeah.
Yeah. Sure it is. Sure.
But it's interesting. You have to have it.
Yeah,
Yeah.
I think so.
Because you really, really do, because it's very difficult sometimes. I mean, especially, with, there's nothing that's harder of a talk with somebody than something like that, right?
My daughter also was working with the immigrants.
When the STEM grant started, the state improvement model, the ones that we got.
So Kennett Square.
Kennett Square and in New Jersey more than
CMS to really redesign here in Delaware. One of the things they did is they created these different work streams. And the workforce work stream
she wanted to be an
one where they're like, we've got to figure out how to prepare for the future.
trauma.
I ended up on that committee.
Well, I think that's something that, I think all of us have an experience doing it, so.
Right. That is true.
Well, it's nice to see you again.
On that, but I was like, I've got
They're just interested.
yeah, so that's why I recommended Stacy. So I'm so glad that she's involved. She's so good. Good. Yes, that is awesome. And actually, we've been talking with, I've been talking
Yeah,
to
and Carla said it's one of
and Neil Kasani is trying to see two things. One is I want to do another underserved track down at our Bear site, get 3 more residents down there. But the other is and one of the reasons I recommended Stacy for that committee was that we want to do an NP residency.
Yes.
And so I think that the framework of the consortium really is ideal for that. So it just depends on how quickly the consortium gets there, whether or not we're able to do it that way, or if we have to do a workaround.
Yeah.
But
That's amazing.
anyway, yeah, it is. It is. I'm so awesome. I'm so glad that you're doing that. That's awesome. thought.